Good day, people. We're continuing in our series speaking about patient position. So this is the second series. So we're looking a little bit more in depth as far as patient position. So we've spoken about seated, we've spoken about lateral. Today we're going to speak about the prone position. The pros, the cons, what is easy, what is hard. Okay, so as far as prone position is concerned, we look back to the previous series on patient positioning and we understand that the table makes stable. So prone is a very good position as far as keeping the patient stable and safe. Okay? So we don't need to worry as much about the second concept, which is less stable means I need to make the patient more stable because they're in full contact. The third concept, the space between us is unstable. We still want to consider negative space between us and the patient as far as the capacity to efficiently apply leverage to help the patient regain lost motion and also to identify it. So in prone position, the benefits, very generally speaking, are it's a very stable position. You're very well able to work on the vertebral column and other posterior tissues. You can actually touch them. Most of this is short lever, so working on the vertebral column in prone is very well done. Short lever, aka hands directly on the structures or as close to directly on the structures as you can be or as you want to be, because you're going to be blocked. Say you want to move the vertebral column, there are several layers of soft tissue between you and the vertebral column, so motion is created collectively or hopefully. Sometimes it's not always created. You think you've created something and it hasn't happened. And we've talked about that over time through all of these videos. Okay, so short lever work on the vertebral column is very effective, very available. Okay, so you can work very specifically. Short lever work on the posterior tissues, posterior soft tissues, whether it be the erector mass, the rhomboids, the trapezius, the latissimus dorsi, other deeper tissues, depending on how you understand your functional anatomy, your labral anatomy, you can affect them. The thoracolumbar fascia, the posterior surface of the abdominal muscle, so as the internal oblique comes back around, the iliac crest is available to you, things of that nature. So again, we have the capacity to work very well short lever on the vertebral column, on posterior soft tissues. You can work the back of the legs, you can work the gluteal region and gluteal musculature. You can quite effectively work through the coxofemoral joint and the soft tissues associated with it there. We'll show that. You can also quite effectively work creating extension with just overpressure. You can create extension from the leg into the lumbar column by lifting the leg off the table, but that's very cumbersome on the operator, on the practitioner, so we want to be aware of that and talk about that and show that. We also can work on the coronal plane, so side bending or lateral flexion. The challenge is that we get a lot of drag off the table. So there is effectiveness at using the limb, the lower limb, to move the lumbar column, really to take the lower limb, put tension on the pelvis from the muscles of the lower limb, and then tip the pelvis onto the lumbar column to attempt to create motion. So a lot of things are happening there. There's multiple joints, multiple tissues moving. So if you can create coronal motion in the lumbar column, although there isn't much, there is some and it can have an effect. But as far as the thoracic column, it's very difficult to work the coronal plane because you have drag on the table, so the patient is stuck to the table, so the coronal plane becomes a little bit more difficult. The transverse plane, aka rotation, is available, but people often overestimate its availability in prone because they can lift one side off the table, so they think they're creating a fair amount of rotation, or as much rotation as is available to the patient. The challenge is that as they lift one side off the table to create rotation to that side, so if I say took my right shoulder and pulled it off the table, I would be rotating to the right, placing tension on the anterior soft tissues, and working as collectively as possible. But the problem is that my other side, my left side, is still stuck on the table, and that'll actually limit motion in the transverse plane. So there is availability of the transverse plane and effectiveness in the transverse plane. It may be overestimated commonly by practitioners. Again, available, but possibly overestimated. And so what we're going to go and do is take a look at these general concepts that we've just spoken about and display them with the patient. So just as a reminder, we're looking at the prone position, very good access to short lever work on the vertebral column, short lever work on posterior soft tissues, the whole posterior surface of the body, some access to the coronal plane, limited by drag from the anterior surface of the body on the table, some access to the transverse plane by pulling the the body off, or one half of the body off of the table, but limited by the contact of the body of the other side of the body with the table. We also do have access to extensions of the sagittal plane, just overpressure, pushing directly onto a structure to try to make it go anterior or essentially backward bend. And please excuse me if those words confuse you. You'll see examples of this, some visual examples, so that it should be more clear. So we have those availabilities. As far as extension is concerned, I just want to say this now before we move on. It's very minimal extension. It's very site-specific extension or backward bending. It has some efficacy, but it is usually aided through patient active approaches, which we can very generally show just so that you have, again, the concept. These are not videos aimed at showing you specific treatment options. They're just aimed at showing you the options available for motions, the effective options available generally. Okay, so we're going to move on to demonstrating with the patient. Okay, so we're here to take a little bit more of a deeper look at prone. So we just did the introduction. We're just taking a look at the prone position. So as stated in the introduction, in the prone position, the vertebral column is well exposed, so I can run my hands all the way up and down it. I can put my hands essentially directly on it through multiple layers of tissue. So the vertebral column is easily accessible to me here, so I can work very well on a short lever or with my hands directly on it. I can work short lever on all the tissues of the posterior surface, so I can work on the erector mass, I can work on the thoracolumbar fascia, I can work on the rhomboids, the trapezius, any tissue that's on the posterior surface, I can work short lever on. Okay. Now, as we said with respect to the sagittal plane, I can simply create overpressure. I can create extension. So as I push posterior to anterior, what I'm going to do is create a pressure that's going to approximate the posterior surface of the vertebrae. So I can create extension here. Now, one of the things that is a problem with that is that it's very, very limited. So that's very good for working specifically or in a small space. It's problematic if I need to work in a larger area. Okay, so what we can do is if we have the patient become active, then we can have greater extension occur. Okay, so I'm going to have you come up on your elbows just as tall as you can. Okay, so very simply, patient becomes active, extension is exaggerated, and I can still work short lever on it. We're not going to do that right now, but I want you to be aware that it's a possibility. Lay back arm down. Okay. In a relative sense, I could create extension on one side of the body through the long lever, through using the leg. The challenge being, the primary challenge being, it's heavy lifting. Okay? So I have to lift the leg, pick it up. So I'm pretty far away from the lumbar column here, but I can reach, and now I have to pick it up. Okay? As we spoke about in other positions, the problem sometimes is that the lever won't go far enough. So in this case, the hip won't go into enough extension to then tip the pelvis onto the lumbars to create the necessary extension. Okay, it can be done, but it is cumbersome because I have to lift the leg, and it doesn't go as far as I may need it to, depending on the actual nature of the motion problem that the patient has. As we said before, we can work in the coronal plane. Again, taking the leg to work in the coronal plane, I can do that, but if the patient has an issue with the lever, so say there's an adductor problem or a hip problem, I may have a bit of a challenge getting the pelvis to tip onto the lumbars in order to create side bending or lateral flexion in the lumbar column. The other issue is that, as we discussed before, there's a lot of drag on the table. So we look at our concepts of patient positioning that the table makes stable. Right? So the table makes stable because there's a large surface area of the patient in contact with the table, but it also creates drag. So the patient's very safe and stable, but there's a drag from the table, so I have a harder time engaging the coronal plane. Now, as I stated earlier, we can work on the transverse plane. Okay, so I can work long lever. I can create rotation by pulling this side of the patient's body off of the table, but I may not get as much rotation as I need because the other side is still stuck to the table. I can do that in a shorter fashion, or a shorter lever fashion, by lifting up here, and you'll see that I can actually get a fair amount more motion. I don't know if it visualizes appropriately, but I can get a lot more motion in the transverse plane when I'm closer to the vertebral column using the pelvis as a handle. I can work quite well on the coxofemoral joint. Okay, I'll just do it across tables so it's a little bit more visible. So I can work on the coxofemoral joint. I can palpate the greater trochanter in order to understand what motion is there. I can palpate through all the soft tissues. I can work short lever on the posterior surface of the thigh, so I can work on the hamstrings. I can work short and long lever. I can work on the knee, soft tissues of the posterior leg, or the shin, the calves, however you want to term it. I can work on the ankle, and I can work on the foot. These are all available to me. I can also work on the upper limb, the challenge being that I have to reach down to get it. So in a case like that, I could sit down to get closer to it, or I could simply reposition the patient to make my life a little bit easier. So again, a very, very general overview of what is available to us in the prone position.